In the second lecture of this series, we will talk about measuring the occurrence of disease in epidemiology. If you remember the steps in epidemiological method, the first step is defining and measuring the burden of the problem. So today we're going to focus only on this, because although it seems and sounds quite easy, I will try to show you that it can be very, very confusing, and it's far from easy many times. All right, so remember epidemiological method, first step, define the disease and then count the frequency of disease in the population. So we're talking about those two things today, all right? Then we can describe occurrence, cross-tabulating it with various possible risk factors, interventions, and so on. And eventually, we may even compare two different groups of population or samples. So that's all fine, but we're not going to be talking about 3 and 4 today. We're mainly going to focus on number 1 and number 2. Defining the disease and count the frequency of disease in the population. So how can you measure the occurrence of disease or the burden of the problem in the population? Well, the first thing that comes to mind is prevalence of disease. Basically, just go into some population, find 100 people and ask them to have themselves diagnosed of disease and establish how many of those 100 people have a disease and how many haven't. And that's your prevalence. I mean, what could possibly be more simple, right? Okay, let's see if it's so simple. So, you would use cross-sectional study, obviously, all right? And prevalence is something that cannot be smaller than 0% and no greater than 100%. So, if you take 100 people, you can have 100 of them having a disease, you can have 0% of them having a disease, nobody, right? And, or anything between that. So, in some point in time, people are either having a disease or not having a disease, and we're measuring prevalence, you would think you're going to get a number between 0 and 100. So it's a number of persons with disease among the number of people who were checked for the presence of the disease. So what could possibly be more simple, right? Okay, let's say that I send you all to measure the prevalence of schizophrenia in a population, all right? And let's say that I send you to Aberdeen, for example, to knock on randomly chosen 10,000 doors to establish the prevalence of schizophrenia in Aberdeen. Why 10,000? Because schizophrenia is a relatively rare disease in the population. Maybe 1 in 100 people will have it. So to establish a proper prevalence, to be kind of sure of your result, whether it's 1% or 1.2% or 0.7%, you really need more people. So 10,000 doors. And then what's going to happen? You come to a door and people may or may not be willing to open the door for you. Once they open the door and you ask them, you tell them what to do, they may give you the correct information, but they may not give you a correct information. And then you may encounter people who tell you that they had schizophrenia 10 years ago, but they're now fine. Do they count or do they not count? There may be people who say that they have schizophrenia, but they're on medication and they're completely fine for the last few weeks, because they've been taking medications. Is this a case or is this not a case? Or maybe someone has schizophrenia and you obviously see that they are telling things that don't have roots in reality, but no one's ever established the diagnosis. So are you allowed to establish the diagnosis then? And let's say that this whole effort in Aberdeen took 6 months to complete. Is this then a point prevalence? Can you consider this to be a point prevalence if it took 6 months to complete? Because point prevalence is you want to take like a photography, like a snapshot in time of the population. So you want to know on that particular moment what was the prevalence. But if it took you 6 months to collect all this, can you talk about this as being a point prevalence, or is this something else? Do you see how many problems? So, all sorts of problems. Now, let's see how to deal with those problems. Firstly, what is point prevalence? Point prevalence is not about how long the study took. It's about the design, again, of the study. So, if the study took 6 months in Aberdeen, but you were basically doing the same thing, going to 10,000 people in Aberdeen and to establish the prevalence of schizophrenia, and you were repeating the same thing day in, day out, then it doesn't matter how long the study took. It could have even taken a year or 2 years, but you were always doing the same thing among some people who could have a disease. You establish whether they do or not. So this still is a point prevalence, and this would still be reported as a point prevalence, although it took months to complete, because in terms of designs, you just got out there and checked 10,000 people and reported whether they have a disease or not. That is exactly what point prevalence is. The fact that it took you physically 6 months to do, that's just the downside of any research. But in terms of design, this would be considered a point prevalence, because you can think of those people, each one of them being checked for that moment in time. So that's the point prevalence. All right? From the perspective of each subject, the information is in that point in time only, and it counts only those with active symptom of disease at that point in time. So that is the point prevalence. There has to be active disease. Okay, someone may be taking medication, but that's still an active disease if they're taking medication. But if the disease stopped and they're not taking any action or medication and they seem fine, then they're healthy. You can't consider them to be an active case. So point prevalence is only interested in active cases of disease, like flu. You know whether a person has it or not, whether they're drinking antibiotics or whether they're taking something else. That's fine, but there is an active case of flu. So that's, and you don't care if they had flu 2 months earlier, all right? So that's what point prevalence is. But now, what is then period prevalence? Because this Aberdeen case sounded like it could be a case for period prevalence, 6 months period prevalence. No, that's not what period prevalence is. Period prevalence relates to the design again, which is coming to a person and asking them, do you have schizophrenia today, or did you in any period in the previous 6 months suffer from symptoms of schizophrenia? So some diseases are intermittent, they come and go, so you can't just know about them by asking for one point in time. In fact, you need to ask about a slightly longer period. So if there is a flu period and you wanted to know what was the total number of people who had flu, you would come at the end of the flu period and ask people whether they're in previous 3 months they had an episode, and that would give you a period prevalence of the flu over the period of the 3 months. So that's what period prevalence is, okay? So it doesn't have to do anything with how long the study takes to complete. It has to do with what is designed. Are you asking people for the point in time, or are you asking people for some period in which they could have had active disease? And then there is third thing, which is a lifetime prevalence, So lifetime prevalence is very interesting because you are interested whether ever in life people had schizophrenia, and that's a very useful information for you. So that, maybe they don't have it for the last 10 years, but they may have had it 10 years ago, right? So regardless of the status of the disease at present, that is the lifetime prevalence. And then there is the fourth kind of prevalence, which is the lifetime morbid risk. This is also something that is of great interest to policymakers. Why? Because it serves them to calculate over the period of the entire life how many people will come under some disease and how many things or drugs they need to have in stock and so on. So basically, although some people didn't get it yet, some people will, and you have to really study the cohort of people for their whole life and look at historic data to see what is the lifetime morbid risk. So to explain this to you very simply, let's say that there are 10 guys who are playing five-a-side football every weekend, all right? So, 5 guys in each team, and they've been doing it for many, many years, and they're all 45 years of age at the moment. They've known themselves since high school or something, all right? So you come one weekend and you want to establish the prevalence of some disease, let's say schizophrenia, although this is very high prevalence for schizophrenia, as we'll see, but for the sake of it, all right? Or hypertension, it could be hypertension. So, 45 years, you come one weekend, they're playing football, and you ask them, each one of them, firstly, you measure their blood pressure? Do you have hypertension now? and you see only one of them has hypertension, that's person 2. So the prevalence of hypertension, the point prevalence, would be 1 in 10, all right? But you could also ask them, over the last 10 years, has a doctor ever told you that you had a high blood pressure? And then this guy here, person 9, would say, yes, I didn't have it for the last few years, but yes, there was a period in my 40s when the doctor told me that I should start exercising more or eating differently or take less salt, and now I seem to be fine, all right? So then your period prevalence over the last 5 years becomes 2 in 10 or 20%. And then you have lifetime prevalence. In that case, person 6 comes into play because they have been treating themselves from some hypertension in 20s and 30s, but now they seem to be fine. So this climbs. And then if you keep following them until they all die, you will get another person suffering from hypertension, that's person 4. So lifetime morbid risk will be 40%. And actually these numbers are even quite plausible probably for hypertension in such a population. So this is how you distinguish what is point prevalence, what is period prevalence, lifetime prevalence, and lifetime morbid risk. You see, even the prevalence, which is like the simplest thing in the world, is not simple. We have 4 different measures of prevalence, okay? And we need to be completely clear about these things, because if we are comparing, we can't be comparing one population in which they tested for period prevalence with another where they tested for lifetime prevalence, or point prevalence with period prevalence. You know, of course, these are not comparable, so we need to know what we're talking about. Okay. Now, there is one more complication. This is just part of the complication, all this understanding of time and periods and so on. But if you remember, we also had a part of the definition like persons with disease. In the formula we had number of persons with disease over all that have been tested. So how do you decide in a field study like this who has a disease and who doesn't? We could see from schizophrenia that self-reporting isn't reliable. People may be withholding deliberately the information, but they may not be withholding it deliberately. They may simply not know. Not everyone is medically qualified. So let's say rheumatoid arthritis. You want to really understand what is the prevalence of rheumatoid arthritis, but people don't know that this is a specific disease, and then rheumatic disease is very common, whereas rheumatoid arthritis is not. Okay, so people will just think that any pain, you know, they feel in their ankles is a rheumatoid arthritis and say yes, or they will not. So basically, or depression, or dementia, people may not be aware. So we obviously need some objective agreed test. But look at the problem with that. Firstly, in the field study, we can rarely use the test that can definitely establish the diagnosis of disease that would be 100% sensitive and 100% specific. So we need to use some method of screening instead, which is never as reliable. Because when we have a person in a hospital and we can do all sorts of CTs and NMRs and all sorts of microscopic diagnosis, then little by little we can establish the diagnosis almost with certainty. But when we're in a field study, we can't do that, all right? We have to use some test which is approximation of those sophisticated tests in the hospital. But now think about this very carefully. What are we then doing? We are not establishing who has a disease and who doesn't have a disease in the field study like this. We are not measuring the burden of disease. All that we are measuring is the number of people who test positive for a diagnostic test that we're using or a screening test we're using. Not the number of people who really have the disease, but the number of people who test positive for the test that we are applying. And that may be very similar to who has a disease, but may be very different, as I'll try to explain. Look, let's say that we're interested in prevalence of type 2 diabetes in the population, all right? And let's say that we're using oral glucose tolerance test to establish active type 2 diabetes, all right? So we challenge people, we give them glucose, and then they should fall after 2 hours to the normal level. If they don't, there's some problem, okay? But look, this is the level of glucose in the blood which you encounter in the normal population. It can range, we are all different. We range in our height, we range in our weight, we range in all sorts of traits that we have. We are all very, very different. We range because we are genetically different, each one of us, and also because the environment is different on the top of genetic differences, and this causes the whole population to be different. And most people will be somewhere in the middle, but then there will be some people at extreme ends because they have specific combinations of genes that are very rare on one side or on the other side, but also they may, on the top of that, be exposing themselves to very strange environments. And this may be normal for people. So for some people, very rare people, it's normal to have glucose this low. For some people, very rare people, it's normal to have glucose this high in the blood, and there's nothing wrong with them, all right? And now there is going to be a subset of this population, very small subset, that does indeed have type 2 diabetes. So these people have lost ability to regulate glucose well in their blood after being challenged. So what will happen? There will be hidden. This is not going to be obvious at the checkpoint. But after they're challenged, their glucose is not going to fall back to this level. In fact, their glucose is going to stay here, and this is how you're going to identify them, all right? You challenge them, and these people who do have type 2 diabetes, their glucose stay here after 2 hours, whereas everyone else's glucose comes back to where it should be. Now, look at this. Where do you draw the line? Do you draw the line here? Do you say anyone who has more than 7.5 after 2 hours has type 2 diabetes? If you do that, what are you going to be measuring? You're going to be measuring everyone who has diabetes. Great, that's what we want. But you're going to be measuring also the tail of the normal distribution, and you're going to get all these healthy people in there. So what are you going to do? You're going to be overestimating the prevalence of type 2 diabetes in the population twofold, because it seems to me that the area under this is just about the same as area under this. So you're going to be overestimating the prevalence. Ooh, all right? But this test is 100% sensitive, all right? Because it's sensitive because it feels every single diabetes patient, it can find it. But it's not very specific because it gets you many people who don't have diabetes as well, you know? So it's not distinguishing them well from those who have it. Okay, so what else could we do then? Do we draw the line here? This test is perfectly specific. Why? Because it makes sure that it doesn't encounter anyone who doesn't have diabetes. But if you take the test which is 100% specific, but it's not very sensitive, obviously, because it leaves out many of the diabetic patients, what's going to happen? You're going to underestimate the burden of diabetes in this population by maybe 10 times, all right? So you overestimated it last time when you were 100% sensitive, you overestimated it twice. Now you're maybe underestimating it 7 or 10 times because you're only capturing these guys, all right? So what do you need to do? You need to deliberately design a test so that it's neither perfectly sensitive, neither perfectly specific, but that it leaves out just as many true cases that it takes in false positives. So it balances those that are left out with those who are wrongly taken in a way that the number that you're getting is really truly representative of this area under the red curve. So if you are doing a prevalence estimate in the population, burden estimate in the population using a screening test of the disease, you need to really understand the properties of this screening test and what is sensitivity and what is specificity, and then you need to play with them and play with these distributions to understand what's going to happen. Because many people in their grant proposals, they have to do power calculation. They have to convince the reviewer that if they see the difference of 10%, that their sample size is going to be big enough to be able to detect this difference, all right? And then they make these estimations on screening tests. But if the screening test is overestimating or underestimating or misclassifying the cases, then it's all wrong calculation about whether the study has power or not. So this is very, very important if you're measuring the burden of disease in the population. And we said that this is our initial first step, which we need to take in epidemiological method, measure define the disease and measure it. So defining the disease here is we need to deliberately define the test, the disease here, so that it's neither sensitive nor specific, but that the combination of sensitivity and specificity is perfectly tailored so that we can actually measure the burden, although we're doing everything wrong, but we still get the correct answer, okay? All right? Because there's simply no test that can be both 100% sensitive and 100% specific in this case, all right? So, when we go to case definition, we don't count the number of disease cases. We count the number of study participants who test positive for a disease of interest using an internationally agreed case definition. If you try to name a few diseases which have a perfect case definition, you're going to realize that you don't have many of these diseases at all. You know, case definition in epidemiological studies have a property of screening test. It has sensitivity and specificity, and the prevalence estimates can be hugely distorted by your population choice. This is yet another problem with prevalence studies. If you want to test for the prevalence of dementia in the population, don't go to retirement homes. Although that's the most logical place to go. All the people are there, dementia is the disease of all age, so why not just go to retirement home and measure the prevalence of dementia there, because there you will find some dementia cases. The trouble is you're going to find way too many of them, because if someone already has dementia, their carers, their family are going to, almost certainly going to try to place them in retirement homes. So if the dementia prevalence in 75 plus population is maybe 10% in the general population, in retirement home it may be 30 or 40%, far more. So there is an enrichment in prevalence. You need to make sure that when you're studying the prevalence, you don't fall under this trap that there is enrichment of the cases for any reason, or that there may be depletion of the cases for some reason, right? Okay? And remember, diseases with perfect case definitions, there's hardly any, you know, very, very few of them, and especially in psychiatric disorders, you know, you need to have 2 out of 3 psychiatrists to agree or something like this. I mean, that's far from the level of precision we would like to have, and in fact, the problem is that we don't really understand the etiology of most diseases. If we did, then it would be far easier to decide whether they are present or not. But as long as we don't understand, for example, breast cancer is now thought of as maybe 20, 30, 40 different diseases. It all presents as a lump in the breast, but when you look at the molecular signature of breast cancers and hormonal receptors on them and all sorts of other properties and features, and whether they arose through irradiation or through hormonal pathway or through mutations or through some other way, you know, they are really different disease, okay? Good, so that was prevalence, which was by far the simplest measure. So now we can go to a bit more complicated measures of the burden, which are also interested. And one of them is clearly incidence, right? Incidence is our favorite in epidemiology. We love knowing about incidence. Incidence is really something it tells us so many things at the same time. So incidence is different from prevalence because it's measured in perspective, in longitudinal studies. It has a time component. Prevalence does have a time component if you're talking about lifetime morbid risk or lifetime prevalence or period prevalence. But frankly, prevalence is something that we think of as, come on, it's just the number of cases in the number of population. But incidence is more beautiful because it has it has a space, time, and population. It's an interplay of all this, all right? So we need time here, and we need time in the future, not time in the past like in prevalence. In prevalence, it's always in the past. Even when you're talking about lifetime morbid risk, you have to do it retrospectively and in the past. But with incidence, you're talking about measuring stuff in the future and disease arising in real time. So people in the sample are all healthy at the start, but they're then followed up to detect new disease cases, and this introduces this element of time into disease measurement. And this is why incidence has this very confusing denominator. It is person at risk times the time of their follow-up. So the incidence is not measured as 25 over 100,000. That would be simple. It is 25 cases over 100,000 person years. Person years. So you have people and you have the time that they have been potentially at risk to develop of disease. And remember, persons at risk. Every word in this definition is very important, as I will show you later. So, number of new cases of the disease, new cases, not relapses of cases that we already established or something. It has to be an entirely new case of disease arising in someone who was previously completely healthy, all right? Over the number of persons at risk, remember this, at risk, times the time of their exposure, all right, or follow-up. And this is why you have to measure it. Look at the unit. Number of cases, so that's just the number, over number of persons, so that's again a number of persons, but time, years. So person, years. Incidence is measured in person, years. So for many people it's difficult to grasp this concept. But actually, many times the denominator in incidence looks like just 100,000, like 25 over 100,000, because year is 1. And then if the year is 1, if this was just done over 1 year, then you multiply this by 1 and you just lose time. But don't forget about it. That is a special case. But you shouldn't forget that this is only because year is 1 that you suddenly don't see it anymore. It's ignored. But that's a special case. All right, so the denominator is person, years, but it could also be much more confusing, like child weeks. When are you going to do it in child weeks? When you come on a weekly basis to a village, and every week you ask the mothers whether their children had some disease, diarrhea or pneumonia or something, in the last week, right? And then you measure it in child weeks. You had like 100 children under surveillance, you did it for 7 weeks, and you express it in, we had like 28 cases of diarrhea per 100 child weeks. And now you have to work out what this really means in terms of population. So the denominator is only based on population at risk to develop a disease. Unlike prevalence, incidence can be greater than 100%. Oops! How is that possible now? How can anything be greater than 100%? Oops! Why? Because if you have 100 children, and you're looking for 1 year for upper respiratory infection, each child will have at least 3 upper respiratory infections in a year, right? But this, remember that this now, when we are saying that the incidence is 300%, this is no longer the percentage in terms of 0 to 100. This is percentage as a number, because now we have a time in the denominator, and this is just a number. 300% means 3. That means there were 3 episodes per year per child, all right? So that's what we're saying. Each child had 3 episodes per year of upper respiratory infection. They are common, okay? So when you say that incidence is 300%, this is not really like 300 of a pie chart, you know, it's not like pie chart suddenly is expanding and breaking. That means that it's just number 3. That tells you that there's 3 episodes per child year. So we're no longer talking in terms of prevalence 0 to 100%. We're talking about the actual number of episodes per person per the time of study, okay? Someone can have 5 heart attacks over 10 years, all right? So the incidence of heart attacks over some time can be more than 100%, okay? So incidence can be greater than 100%, but can't be smaller than 0%, all right? You can't have negative episodes of disease, all right? I hope not. So incidence is hugely sensitive on underlying population, on age distribution, gender distribution. So if you're comparing incidence in one population with another population, you absolutely need to standardize before any on any risk factors or anything that you know affects it before you are making any comparisons. Now let's try to explain this. If in a town of 100,000 inhabitants you have 30 cases of prostate cancer over 1 year, what is the incidence of prostate cancer in this town? Is it 30 cases per 100,000 inhabitants per year, 15, 60, 3, or 300? What would you say? 30 per 100,000 per 1 year. So what would you say? 15. You're saying 15. Anyone else for 15? Or anyone else for 30? Who is for 30? 4, 5, 30. Who is 15? Rutuja. And any other opinions? You think 30? Okay, so 6 of them are saying 30. Rutuja, you can't possibly be right, can you? Or can she? what did we say is the definition? Number of persons at risk. How many people in this city were at risk of prostate cancer? Half the people. All right. So Rutuja is right, all of you are wrong. Sorry, guys. Very, very well done. She was paying attention. I said at risk. Women were at no risk of prostate cancer. So the incidence is clearly only among males here of interest, not among the whole population. All right. See, you have to be careful in epidemiology. Very easy to make mistakes. Look at this. The colors may not be that different between, but anyway, look, this is kind of blue and this is kind of like the background. So it's too light blue, unfortunately. So let's say we are having a report that in some prison there is an epidemic of tuberculosis. And we need to establish whether this is really an epidemic or something that is expected, okay? So how are you going to do this? We need to see if we are talking about epidemics, that means new cases arising. And we need to see if these new cases are arising at faster pace than they're expected to be arising. But how are we going to do this if we have 18 months to establish whether there is an epidemic or not? How are we going to do this when we know that some prisoners, we can take 10 prisoners. This prisoner came here and left there. This prisoner came in month 3, left and stayed on. This prisoner came in month 9 and served the sentence by month 16. Prisoner 4 came here. This, they have different sentences. They're coming in and going out. And this is establishment of the case of tuberculosis. So we had 5 cases, but we had 10 prisoners, 5 cases, but we can't divide this 5 by 10 times 18 months because not all of them were there for 18 months. So we need to make sure that for each person we specify the amount of time spent in prison and add them all up because that was the period of time over which we really observed 10 people. And then you have 5 new cases versus 10 persons times 10 months because average time spent in prison for each prisoner was actually 100 months all total per 10 persons. So basically you had the incidence of 5 person months. All right. So that's that. And then let's move on to mortality. Mortality is really exactly the same as incidence. There is no difference between incidence and mortality in terms of design and calculation, apart from one very important difference, which is that you can only die one time so far, right? We don't have a way to bring you back yet, and then you can die again. So it would be nice that if we did, because then mortality could be more than 100%, but mortality is only between 0 and 100%. But remember, this is not because it's limited by like a pie chart. No, this is only because you can only die once, whereas in incidence you can have disease several times over a period of time, whereas you can only die once. So this is different from prevalence, because in prevalence you can either have a disease or not at one point in time. But here it is about death being an event which can only happen once in any given amount of time, So, so mortality can, but otherwise it's basically measured and computed in the same way as incidence. You take some people at the start and you let the time run, and you're measuring the intensity over time of dying. So basically, you see, the prevalence is a snapshot of a population in a point in time, whereas incidence and mortality are really measuring the intensity in time of how intensely disease arises and then how intensely people are dying. Because if you have a population of 40-year-olds somewhere and they're intensely dying, that is hugely strange and completely different from a population of 40-year-olds in some other where no one is dying or hardly anyone is dying over a year, right? So, so that's the thing. Now, what is a case fatality? That's mortality divided by incidence, and it's very useful because it's serving us well in dramatic epidemics of infectious diseases or other abrupt events with immediate mortality risks. So what do you want, where do you need case fatality? You need to know case fatality when there is an epidemic of Ebola or something. You very quickly want to establish how dangerous this is. You know, out of the first 100 people who contracted the infection, what proportion of them died? Was it 10% or 60%? You know, if it's 60%, then there's going to be a massive panic. 10%, that means that you can contract it, you still have 90% of chance of making it and surviving, right? And then lethality is really the same as case fatality. There's not much, I mean, it's very difficult to explain the true difference fundamentally between lethality and case fatality. It's just usually that we speak of lethality when we're talking about more chronic conditions, and time component is somewhat blurred. Case fatality is usually really thought of in acute events which are dramatic. Lethality, you can talk about lethality from HIV, AIDS, for example, and then if you're talking about the whole life, it was 100% in the beginning, but now we have drugs, and some people are now dying from other causes rather than HIV because they're on antiretrovirals. So, you know, lethality is not used as commonly. Case fatality is really what we need to know when there's some acute event, all right? Now, let's try to think about the relationship between these three things. You have incidence, you have mortality, and you have prevalence. So let's think about a disease which has a low incidence and high prevalence. So if you're looking at dementia, dementia is such disease because you contract it and then you carry it for a very long time, so the prevalence can build up in older age groups to 30% perhaps in very old age groups, but the incidence is not going to be that high because, you know, it's not like disease that springs up all the time. It rarely springs up, but it accumulates because it stays with you, right? So the prevalence accumulates, but disease rarely hits, all right? But the prevalence accumulates because it stays there. High incidence and low prevalence. Influenza is a good example because if you take a point prevalence of flu, it's always going to be reasonably low. But then, you know, 40% of the population can have flu over 6 months. But at any given point in time, you would not necessarily find more than few percent of population having it. So then high case fatality and low mortality. A sudden acute respiratory infection syndrome severe acute respiratory syndrome was one example. That's a reasonably recent epidemics that hit us of a strange infectious agent. So it had a high case fatality but low mortality. What does this mean? That means that among those people who were affected, quite a few of them died. It was a high percentage of those who were affected that died. But in terms of overall mortality in the population, so few people were affected in the first place in those airports or whatever it was spreading, that in mortality it was almost insignificant for that year. But among those who were affected, the case fatality was very high. And then you can have low case fatality and high mortality. For example, diarrhea is a great example among children because, in fact, you have billions and billions of episodes and hardly anyone ever dies. But because of so many episodes, if you look at all child deaths, diarrhea is a major cause of child death, and it causes major mortality because so many episodes that even when rarely something goes terribly wrong and the child dies, this still accumulates to quite a significant mortality in the population simply because there's just so many episodes of low case fatality. But even that low case fatality turns into quite a high mortality because of the repeated episodes all the time throughout the year, right? So you can think of it as a bathtub, you know, and the incidence is, as we say, cases arising, so the water coming into a bathtub. Mortality is, again, cases leaving, people dying. And then the prevalence is really going to be the difference between those two. If you are having a lot of water coming in, like from the fire hose, and very little coming out, then the prevalence is going to build up, like with dementia, right? You know, or not dementia maybe, but some other disease. Whereas if people are going to die instantly and then the diseases don't occur that frequently, but they always lead to death, then clearly the prevalence will not have time to accumulate and to build up in the population. You won't see many cases at any given point in time. And then you can have recurrent episodes contributing to prevalence again. Okay, So, going back to epidemiological method, if you remember, we said define the disease and then count the frequency of disease in the population. We've done that. Now, describing the occurrence of disease in the population in time, space, by age and sex, and then comparing the disease occurrence between two different subpopulations. We're going to now try to think, okay, what when we have those incidences, those prevalences, those mortalities? They're clearly only specific for a population in which we measure them, right? But we said that they can be totally different in different populations, and we should be very careful about any enrichment of the cases and population being strange or unusual. So when we compare two populations in epidemiology, it's very important that we are comparing like with like, because otherwise we're going to reach completely wrong conclusions. And we say that the comparison of apples and oranges occurs when two items or groups of items are compared that cannot be validly compared. Okay? So, let's say that we need to compare the number of newly diagnosed cases of lung cancer in two countries. In all age groups, country A had greater incidence of lung cancer per 100,000 population last year. So we're talking incidence, number of cases of lung cancer per 100,000 people per year. That can be both males and females, so Rutuja cannot be the only one right this time, all right? So we're talking two different countries. Each age group you look at, each age group throughout from start to finish, one country has a greater incidence of lung cancer per 100,000 per year than other country. Which country had more cases of newly diagnosed lung cancer last year? Is it country A, which has greater incidence of in all age groups? Is it country B, or is it we can't be sure? What do you think? Come on.
C.
You think C? Anyone else? What the rest of you think?
C.
Everyone thinks C? Ooh, now you got very careful after that last time. Huh? Now you don't want to go for the obvious anymore, huh? Okay, so we can't be sure. How come we can't be sure? If you cover all age groups from start to finish, from 0 to 100, and in each age group, country A has a higher incidence than country B, how can then possibly country B have higher incidence than country?
We know the specific numbers of the population. So
let's see. All right, let's take two countries which has about 1 million people. Actually, Gambia now has up to 2 million already, but it was very difficult actually to find two countries with 1 million people. Usually countries either have many more people than 1 million or much less if they're those small countries. 1 million is a funny number to find for a country. Okay, so let's say, look at the age distribution in Estonia. In Estonia, people less than 45 years, all right, so 45 to 64 and 65 plus have 10, 40 and 90 per 100,000. Gambia, 20, 50 and 100. So if you look, the Gambia people have higher incidences of lung cancer in all age groups than Estonia. But then what is the total? This is the age distribution of Estonia. You can see that most people are somewhere in the middle. There's many old people. And this is a comparable age distribution of the Gambia. You can see that most people are children and young people. There's very few people who reach old age. You have a tiny number here, 80 to 84, and then hardly anything above that. Whereas in Estonia, you even have people older than 100, all right? So look at the numbers of people in each of the age group. Less than 45, here 300,000, here 600,000. 45 to 64, 400,000. Everyone in the middle, here 300,000. 64 plus, 300,000 still in Estonia. Here, 64 plus, merely 1/10 of the population, right? So when you know that, you multiply your incidence with the population, and how many cases do you get? 10 per 100,000 in 300,000, that's going to lead to 30 cases. 40 per 400,000, 160 cases. 90 per 100,000, that's going to give you 270 cases. Altogether in Estonia, in 1 year, you're going to have 460 new cases of lung cancer. And these are new cases over 1 year, So you can calculate the incidence. New cases, 460, 1 year per 1 million people, now the whole population, all right? And you get 46 per 100,000. That's your incidence for Estonia. The Gambia, you do the same. You get 120, 150, 100. You get 370 per million, 37. So if you just looked at the so-called crude incidence is completely non-standardized. Crude incidence in those two different settings in their populations, you would conclude that the Gambia has less lung cancer than Estonia. But in fact, when you do the standardization by population, if you look in detail, you realize that the Gambia is much worse in every respect. It's just that their age and sex distribution of the population makes it seem like they are better off, whereas they're really not. They're obviously smoking far more and getting far more lung cancer than people in Estonia, right? But that's not very obvious because of the age distribution of this disease, all right? And the population. So you have to standardize. Before you compare incidences, you have to standardize at least by sex and age. And how do you do this? You introduce something which we call standard population. And how do we define standard population? Well, this is the beauty of it. It can be anything. It doesn't matter. We don't have to have a specific standard population that we all agree on. All you need to do is make up any population. Just make sure that it has well-defined sex distribution and age distribution. If you do that, and then you can take as many countries as you want, or as many populations as you want, and standardize the incidence according to that population. So take those age-specific and sex-specific incidences, multiply them by the number of people in one standard population in that age and sex group, add all those cases together, and you are going to get the numbers that are going to be comparable. And it doesn't matter how you define or structure that standard population, whether you put many people to be old or many people to be young, doesn't matter. The only thing that matters is that you take all the specific age, sex incidences and multiply them to the same number every time, and then you can make comparisons. So then you standardize it. And it doesn't, so it can be standard world population, it can be standard European population, but it doesn't have to be any of it. It can be just a made-up population completely. You can say that there's equal number of male and female and equal number of people in all age groups, and or any other way, and you're always going to get the same result. You're always going to get the same rank of countries if you're using the standard population. All right, you can't suddenly twist anything anymore, because then you really see the effect of those specific age and gender specific rates. All right. Okay, so I think now that you have learned a little bit about how confusing it is even to measure the burden of disease and to define the disease and to actually compare various populations in epidemiology. But this is what epidemiological method is about. We now took you through all the steps, and now you should be able to protect yourself from any mistakes that people usually make when they are designing their studies. So thanks very much.